Hi, everybody. I am so glad that you are back listening today to the Deep Sea Journey podcast. But as I often say, if you want to watch our conversation, you can also see it over on the DiepCFoundation YouTube channel. We have a topic today that I have just been fascinated with, and it's funny kind of how the stars align sometimes and how I get my guests to come on. This is a topic that has been brought up in the community that I serve at DiepCFoundation, and it's on pain control after, specifically in my community, after breast surgery and breast reconstruction. And it's something that we have addressed on the podcast before, in previous episodes, specifically talking about ERAS protocol, which is enhanced recovery after surgery, which surgeons are still using for breast reconstruction surgery. However, today we're going to discuss Journavx. And believe it or not, it's a first new class oral pain medication to be approved in 2 decades. Yes, you heard me right. That's 20 years. And Journavx was, in fact, approved in January of this year, 2025. It took a few years of clinical trials to be quite clear for the FDA to approve this. Now, I'm going to attempt to say the pharmacological name, but I know my guests will correct me if I'm wrong. I put it phonetically for myself. Suzetrigine. I don't think that's right. Suzetrigine. Ooh, that's a
You
mouthful.
got it.
Okay. All right. I got it. Thanks. So, um, I, I was seeking someone who's medically trained to talk about it, but also had personal experience. And I found those two people who possess that dual skill to talk about Journavx today. Really, they're friends of mine. I've known them for a few years in the medical community. We have gone to medical conferences together, but also sharing contents, sharing educational content in the breast cancer community. They're returning guests to the podcast and DiepCFoundation YouTube channel. I'm joined today by Ann Peled, who is a board certified and dual trained both in plastic and reconstructive surgery and breast oncology surgery practicing in San Francisco. Ziv Peled is a board certified plastic surgeon trained to perform the full spectrum of aesthetic and reconstructive plastic surgical procedures with a special emphasis on peripheral nerve surgery. Now, they don't have the same last name by coincidence. They are a married couple who have 3 beautiful children, and Ann and I have something in common. I'm calling them by their first name today because they are friends, but because of the Peled name, I'm going to take the opportunity to call them by their first name when I address them today, if you guys don't mind. But we have something in common. I often call it being in the two-timer club. We both are two-time breast cancer survivors, and Ann and Ziv have been recently in a new role of recovery in Ann's very recent breast reconstruction surgery. So, wow, it's so glad to see you guys and to see you both smiling. How are you doing? Welcome back.
Thank
Thank
you,
you.
Terry. It's so nice to be back. I think your introduction was perfect, and I feel like our lives overlap in so many different ways. And one of the ways I am grateful for is the role that you play and that we try to play as well in terms of education in the breast cancer and breast reconstruction community. So really grateful for all of the different topics you cover, and so glad to be back talking about this one, which has played a really big role in my journey. And Ziv, with all of his peripheral nerve expertise, is really a great person to talk about the science. So we're really glad to be on today.
Yeah.
Thank you so much for having us. Really looking forward to this conversation.
Oh, me too. You guys are two of the best people I could find to talk about this, so I'm excited. Um, what I want to really point out to the listeners is our lifestyle. And Anne and I seem to parallel in so many ways. My husband and I are organic gardeners, and we kind of like the farm to table, the whole farm to table experience. We cook together. I going out in the garden is kind of a Zen experience for me. And I see you and your children fixing healthy meals together. You're doing yoga, which I do every morning. That's non-negotiable for me, for 10 or 15 minutes to start my day. So, Anne, can you just tell the listeners how the second diagnosis hit you and what's your message for those listening today?
Yeah, thank you, Terry. And I do think so many parallels. And I think one of the things that's so important for people to hear is this healthy lifestyle component. A lot of times when people are diagnosed with breast cancer, I see in my own practice, in our community, let alone a second time, is that it's something that they've done wrong or they haven't done enough of. There's so much guilt that we see with the diagnoses. And I have to say, I think one of the things that's been really powerful going into this, I was first diagnosed in 2017 at 37 and then was diagnosed again 8 years later, actually with the same breast, different cancer. And it felt so crazy at 44, very healthy to have these two cancer diagnoses. And honestly, it makes you wonder, again, could I have done more? And I often think to myself, like deep in my heart when I sit with it, I know I really couldn't have. Like I did all the things. I work out every single day. I do everything you talked about. And sometimes cancer doesn't care, it just happens and it's part of our community and part of our world. And I think being able to kind of let that guilt go has been huge for me. And also reminds me that doing all those things, like you spoke about, makes recovery so much better. The work I did, I worked out with a physical therapist, a personal trainer, all the way heading into my surgery. I've been getting back as soon as they safely can after my surgery. And I have to say that strength, the routine of meditation and yoga and wellness and having a family that supports all of that and does the same has made this recovery so different. And so I'm very grateful for all of the work that I've put in. And I hope listeners will hear, like, if you do all those things, don't stop doing them. It doesn't mean that they didn't serve you well. Actually, quite the opposite. Like all of these healthy choices serve you well. They help your recovery and they help you for the rest of your life as well. So that's kind of been a major learning point for me going through this is actually the power in choosing your health and taking good care of yourself, even with cancer on top of that.
I could not have said it any better. That's
I know you feel the same, so I
Good that
love being
way.
able to talk to you about it, Terry.
I do. I do so much feel that way. And I think letting that guilt go is such an important message and to keep moving. We know how important that is. So, um, okay, I'm going to get into some really scientific stuff here now, and I'm going to turn this over to Ziv. I mean, peripheral nerve surgery, pain, all of those things. I would like for you to kind of explain this pain medication for us, Ziv, but I want to start with a question. I think it's important to do this because this class of oral pain medication, um, I want you to explain the difference between acute versus chronic pain because this is meant for acute pain. Can you do that for us to start
I think
out?
that yeah, absolutely. And I think that's an incredibly important distinction. So Basically, acute pain is much like it sounds, it's something that is relatively new. Most studies would say anything that is less than 3 to 6 months in its presence is acute pain. And typically, a lot of this is post-surgical or post-injury pain, and certainly post-surgical is what we're talking about right now. The difference from a physiologic in terms of what happens in the body standpoint is very different also. So chronic pain being something that's been around a lot longer, the changes and the things that occur are much more widespread. So for example, if you cut your finger and injure a nerve and something goes numb, there are changes that occur within the nerve as it tries to heal and regenerate, just like the scar, that are very focal. When that nerve injury has been around a long time, and obviously we know because if you have touch hot stove, the messages go back to your brain saying that's hot, and almost reflexively you pull your hands back and then you realize you're having pain and it burns. So messages and nerves go back and forth. When those nerves very peripherally, meaning not in the central nervous system, meaning brain and spinal cord, so let's say way out in the finger, get injured and they do not get managed appropriately, those constant messages that there's a problem going back and forth basically sensitize the other nerves in the nervous system. So most nerves will have two other relay stations to get to the brain. The nerve in the finger will connect with a nerve just at or just outside the spinal cord. That second nerve will go up to the brain and connect with a third nerve in the brain, and that'll tell you that you have pain. So the chronic pain pathways, there are many parts to that, but when you have constant abnormal messages going back and forth from a peripheral nerve, those second and third nerve connections become hypersensitized. And then even mild stimuli at the fingers and elsewhere can lead to a hyperexcitable over response, thus leading to what we call central sensitization, where you have this basically chronic process that even if you were to fix the nerve at the finger, that process would have to dial itself down, usually over many months and sometimes years. So it's a very different process. We have acute pain, focal injury, chronic pain, where that nervous system has been overly sensitized over a very long period of time.
Okay, that was well explained. Now, I have a question because I've read about this. I always like to know the mechanism and how, pain medication works. And I'm going to have you explain it. It's out of my wheelhouse. There's a term called, and I think this is what this is working on, sodium channel inhibitors.
Mm-hmm.
Yeah, you're both shaking your head.
Yep.
I don't care who takes
You got it.
that's the pain pathways that it's working on. I'm bringing this up because, whether there's surgeons, nurses, patients, anyone listening to this, I felt like this was an important kind of topic to understand.
Yeah. So going back to the physiology, taking one step further back, most traditional pain medication, when we think of that, which are opiates or narcotics, they work on certain receptors in the brain, so in the central nervous system, to try and basically blunt your ability to perceive the pain that you're having. And I certainly can't speak to everyone else. I'm sure it's different, but I remember one time many years ago, I had to take one pain medication because I broke my nose. And I remember sitting there thinking, wow, I'm still in a lot of pain. I just don't seem to care as much. But the pain is still there. And the other problem with that kind of treatment is because the traditional pain medications act centrally, some people, because everyone is different, will experience certain pleasant feelings of euphoria. And that is one of the many reasons it's thought that those opiate medications, the traditional ones, carry such a high potential addictive set of properties. So if we then take a step aside, if you were to cut your finger, how does the message get to your brain that says, I'm having pain? Well, basically, when a nerve gets stimulated, there are certain channels within the body of the nerve that allows certain chemicals, or called ions, to flow back and forth. Normally, most of those channels are closed, but when you stimulate a nerve, in whatever way you do it, some of those channels open, and sodium, for example, rushes in and calcium rushes out, and vice versa. And that creates a certain electrical difference between the outside of the nerve and the inside of the nerve. And an electrical impulse begins to form along the nerve and starts to send the message back and forth. So the really great thing about this medication is it works on a very, very specific type of sodium ion channel, and it blocks it, and it has an affinity for this particular kind of sodium channel that is found predominantly in the pain sensing neurons. So there are lots of sensory neurons in the fingers, those that can feel hot, cold, vibration, temperature changes, light touch and pressure, and pain. This particular sodium channel is found predominantly on those pain sensing neurons. And when you block it, if you've had surgery, which in most cases involves an incision and some dissection, and those neurons are trying to send the pain signals, this works by basically blocking those to really turn down the volume on those pain messages. And because it works in the peripheral nervous system, there are no central side effects for the most part. So you don't get euphoria. You don't feel kind of cognitively impaired like many people do when they take opiates. And because of that, and we don't have the long-term data, because as you correctly mentioned, it was just approved a few months ago, but there's a lot of hope that we have basically either eliminated or taken a huge step toward eliminating the addictive potential for this medication, because if you take it and you don't have pain, the reality is you'll experience nothing because it's got nothing to do. And so the abuse potential for this, I think, is way down. And so it's very exciting. It really treats the source of the pain exactly how it should.
So, Anne, you're nodding your head.
I was actually just thinking, Terry, so first off, I don't give talks with Z very often, if you will. Like, I don't get to hear him explain a lot of this stuff because we're usually running around at meetings different in different places. And I was thinking, like, A, Ziv, I love hearing you explain nerve related things. Like, you just do it in such a clear way. And B, I haven't thought about sodium ion channels and how they work since I was in med school. And you were talking, and it was so fun to remember there is some stuff back there still from that all popped up. So I just think A, it's the coolest, and you did such a good job explaining it. But B, all the stuff Steve's talking about in terms of side effects, when we get to that part, I just can't wait to talk about as a patient having had this medication, how different that experience is compared to what I see with narcotics. So lots of smiles all around for many reasons.
Well, yeah. So because you're smiling and nodding your head, now I have to go straight to your experience, Anne, because, as we're recording this, what are you 2 weeks out of your surgery?
Yeah, it's just 2.5.
Yeah. And I mean, you look amazing. So how was it administered? You took Journavx. So tell us how it was administered. Did you have any side effects? What was the difference between your pain medication with your first surgery and this surgery? That's a lot of questions, but I'll just sit back and listen to you now.
No, it's great. I mean, I think so. My team told me that I was going to be having Journavx even at my pre-op visit. And I was really excited about it because I have to say, I have now had this is maybe my fourth or fifth breast cancer reconstruction related surgery. I had to have nasal reconstruction due to a car accident. I had 2 C-sections. So I've had a lot of surgery, and I've really tried hard to avoid any narcotics because I hate nausea so much. I'm a person that gets seasick and car sick, and I'm used to nausea. And honestly, that was the thing I was most worried about. And having had nausea for one of my surgeries where I didn't have a great ERAS protocol-based surgery, I really didn't want that again. So in general, I try to avoid narcotics. And obviously there's a lot of other side effects that come with that, but nausea was a big one. But then to think about the fact that I could also really be in a place where my overall pain control was going to be so good that I maybe wouldn't even think about wanting them or needing them, but not taking them to avoid side effects. Because I do want to add, I will say when I posted about my experience with it, people did comment that they think sometimes surgeons don't give people enough pain medication or they avoid giving them narcotics to avoid that. And I want to say, I think the best part about pain management in my mind is finding the right thing for each patient that kind of treats their pain but also minimizes side effects. So I kind of felt like this might be that perfect in between. And so for me, I took it before surgery. So some of your listeners, viewers might be familiar with a lot of the ERAS protocols. People actually take medication in the pre-op area.
Yep.
So sometimes we're giving them Tylenol, we're giving them something called Celebrex, a COX-2 inhibitor that helps with pain. So we're kind of already giving people pain medications, if you will, even before they go in. So I had my Journavx in my pre-op area. And then they had me take it twice daily as long as I was uncomfortable after surgery. And I stayed on it for probably about maybe 5, 6 days just to make sure. But I have to say, I barely took any even ibuprofen or Tylenol in between, which was very different than before. I've honestly been trying to kind of hold myself back from trying to do more just because I do feel like the whole experience, I've had much less pain overall than I was anticipating and what I think I see in general with people going through mastectomies and implant reconstruction as I did. And then the last one, I mean, Ziv, please feel free to jump in on this one if I'm correct in my thinking, but I wonder if that kind of maybe pain cascade that people get into, if you never had a lot of pain in the first place, maybe your whole process, you sort of start in a better place even once you're off the pain medications. And so I kind of feel like I've had that experience where the first week went so well that even into the second, now heading into my third week, I just have really felt great. And I wonder, again, it's hard to know how much is specifically the medication versus the preparedness, like we talked about, but I do think it feels like a different experience.
Yeah, and I think so. You're absolutely right. I think people who already start with a hyperexcitable nervous system tend to require a lot more to kind of tamp everything down. Um, and I think that uh, that also ties in the acute phase. In other words, if you are able to basically, from the time you wake up, block a lot of these pain signals, the ramp up to that hyper excitability doesn't occur to the same level so that when the medication goes away, you're not coming down off a high, so to speak, and things are much more stable and steady state. And that actually made me think of one important point as you raised you were talking about your experience. And the one other component here in terms of how you take this medication is, unlike narcotics, which most people should be taking on an as needed basis every however often it is, this one you should be taking consistently for as long as you use it, because you want to keep that nervous system tamped down from a pain sensory standpoint a little bit. It doesn't eliminate pain, but it can really turn down the volume on those pain signals. And then eventually, if things never get that bad, there's not a lot to come off of. And so when you stop it, you can actually just stop it altogether. But you should be taking it consistently in those first few days.
You both brought up a couple of points that I want to touch on because it's curious to me when, and you do this every day with your patients, pain tolerance varies.
Mhm.
I've heard some patients it's the way it is. Some people tolerate pain more than others. is this medication, if I'm asking the question properly, is this going to help kind of even the playing board for everyone, those who have a low pain tolerance and those who have a high pain tolerance? Because what I heard you say, Ziv, is that it's that the important part is that pain management.
Mhm. Yeah, that's one of the million-dollar questions with this medication that I think is still unknown, but is one of the more exciting things about it. I think that it's possible that, people who, for example, are deathly afraid of getting injections and
Mm.
need to be sedated and all, those sorts of scenarios might be able to take this for 1 or 2 days before surgery. You'll have no effects because you don't have pain, or before their procedure, sorry, and they won't have any effect except what's occurring internally. And then you get the shot and you're like, wow, that wasn't all that bad. Like those people who quote unquote have the high pain tolerance and for whom that doesn't create as much of a response in their body. And I
Mm.
think the other thing that is really exciting about this is how will this work from a long-term chronic pain standpoint? I've had a number of my patients reach out um, who have pain in other parts of their body and say, can I use this for my chronic low back pain? Can I use this for my hip arthritis? And I have a sneaking suspicion that we'll be finding that we can use it for a lot of different things moving forward. But I do have to say at this point, because it's so new, even amongst the clinical trials, it hasn't been studied on a longer term basis to be able to say, oh yeah, you could safely take this for 5, 10 years, and it's no different than your blood pressure medication or a statin. So if you're doing well with it, you can just continue on for as long as you want. But
Mhm.
those studies, I'm sure, are underway.
Oh, yes. I was listening to two physicians. One was an anesthesiologist, the other was a cardiologist who were talking about the drug recently on another podcast. And they said that's the next frontier in research, not
For
acute
sure.
pain, but chronic pain.
Yeah.
Um, so I have a question, and for you. So the other thing I want to point out is, and correct me if I'm wrong, please, but this is the way I understand it, that this Journavx or Journavx is an additional tool, not a replacement. So, in other words, if someone needs a narcotic drug, if their pain, speak to us about that. If their pain is out of control, what were you told in consult, prior to your surgery? Okay, we're going to use this. If there's needed other pain medication, do you know what I'm asking? Opioids, because people say that they go, well, it's not working for me. I need stronger drug. Talk to us about that.
No, I love that question, Terry, because again, everyone's different. And I'm sure you feel the same way anytime I share my own experience, whether it's pain medication or recovery or anything else, I try to explain everyone's journey is different, right? And the last thing I want is people to feel like, oh, well, this is all I should be taking and suffering. So I love your question. And I think the answer is yes. As Eve said, the idea with this is kind of your baseline framework, and you take it twice a day, and so that's 12 hours on either side that you might need something else. And so certainly my team gave me a combination of higher dose ibuprofen, Tylenol, and a narcotic if I need, and a muscle relaxant actually, if I needed any of those. And that's certainly what we do with our patients in general too, is sort of encourage people to have your baseline. We do ibuprofen, but I think we may change it and evolve, which I love being able to do. But we have, here's your baseline, and then here are your multiple things in your toolbox to add in between. Because some people do great with some medications and some really don't. And that's true for regardless what type of medication it is. So yes, I love this is one thing in your toolbox, but it doesn't mean that you shouldn't get or that you shouldn't take anything else if you need it.
Side effects.
Side
Did you
effects
have
are
any?
real.
Did you
I
have any?
really didn't. I didn't have any, but I was thinking the side effects. What I worry about is the side effects of narcotics from nausea to, cognitive to constipation. They really are, it's a pretty long list for most people. And some people will tell me the side effects of narcotics, for some of them can be worse, especially taken over a long period of time than having had, the surgery itself. And so I did not see any side effects with Journavx. But again, really grateful that I didn't need to manage additional side effects to get to be, have my pain controlled. So that was a big win.
The other thing too is I think about the importance of getting your body function back to a normal state. Don't you think that this has to have something to do with that? I know, and then it's been years ago, but I had an ovarian cyst removed, and that's all they had. No air ass. It was opioids. I remember walking into the bathroom in the hospital and looking at the mirror. You talked about the cognitive, you know, brain fog and everything. I walked in the mirror and I looked at myself and I was so scared what I saw. I went back in the bed, hit the nurse's button, and I said, "Get me off of this stuff now." I was so I'm making this point because I hear people say with AirAss, and I can't help but think with Journavx that you're getting back to a more normal state. Your body is quicker after surgery.
I think that's so true, Terry. And I think it's also key for when you think about the things that help people recover. We know that movement, stretching, walking at the appropriate time, all of these things make a huge difference. Mobility, tightness, all the things that we see that really we encourage people. The hope is after a mastectomy and reconstruction that by 6 weeks, you're going to be pretty close, hopefully, to where you started. And I think that would be really difficult if you're lying in bed, not feeling like you can move, managing other side effects. And so, yes, I love that. At least for me, I just had a weekend with Ziv and the kids and trying to remind myself, I certainly can't go running, but I definitely felt like I had a pretty normal weekend in terms of day-to-day things that I could do. And I think that's unique with some of the current pain regimens that we have.
Yeah.
And I think the other way to think about this is sort of very similar physiologically or pharmacologically to the prehab you were talking about, being in a good place physically, obviously psychologically and mentally, etc., before your operation really helps you kind of get back to that baseline after your surgery. I think one of the things that I think is really exciting about this pain medication is pharmacologically, if you can sort of prevent your body from the typical normal physiological reaction to an operation, having an incision, cutting things open, taking things out, perhaps putting things back in, etc., and you can dampen that response from ever getting to that, to this high level, but down to here, you have much less to recover from physiologically. And I think that that also will help kind of get you back to your baseline a lot faster. So
Yeah.
in one sense, it's pharmacological prehab.
Yeah. Yeah. And something that I didn't clarify ahead of time, Anne, and you can speak to this because I know that the listeners are probably curious, is what type of surgery that you had 2 weeks ago specifically?
Yeah, thanks, Terry. I appreciate that because I will say, we know the different kinds of reconstruction do have pretty different recoveries in many ways. So I had a bilateral mastectomy with over the muscle direct to implant reconstruction with nerve reconstruction and preservation performed by this lovely husband of mine. So, which was a lovely side benefit. And I will add, when you think about normalcy, I do think having a surgeon and a surgical team who are committed to trying to preserve any nerves that can be safely preserved during your mastectomy is only going to serve you well also. So just the degree of kind of sensation I have around at least the edges of my chest so far, I think is also really, really serving me well. So I got lucky with that. But again, I think over the muscle reconstruction is much easier to go through than under. I only had one place to heal from. As you know, going through a deep is a whole nother level of recovery. And so I think my experience, again, may be more unique, if you will, compared to some other kinds of reconstruction. I'm just not sure, from a pain standpoint, how much this will help and what that will look like in people who had, let's say, flap reconstructions. But I hope we find out. I think it'll be really amazing to see if this becomes kind of part of the ERAS protocol for many people now in a way that a lot of other modalities, from nerve blocks to non-narcotics, have all kind of become part of the standard flap reconstruction protocol.
Well, I have to tell you, part of my wanting to do this podcast and talk to you both is the questions I had in my own community. There's women that are going to be using it or have used it. I know where to find out how it went for deep flap. So I'll keep
Yeah,
you.
that's great, Terry. Perfect. Yeah,
Yeah.
that'll be a great thing to add.
Yeah. So a couple of other questions, either one of you can answer this, because again, I think people are going to want to know is how readily available is this? It has been FDA approved. Is it major hospital systems when people go for their consult? How readily available is this going to be for breast reconstruction of any type? And the tough question always, insurance coverage. It's a new drug.
So right now, my understanding is it's only FDA approved in the US. I was actually recently looking at a patient who had come to see me for a different kind of operation in Canada, and it's not approved there or in any other country as of yet, although I have no doubt it's coming because it's been so successfully used and so well tolerated so far in the United States. So I think that's just a matter of time. Insurance, much like any medication, it tends to be a little bit on the expensive side to start. Generally speaking, if you pay retail price, so to speak, from the manufacturer, it's about $15.50 per pill, which makes it about a $30 a day endeavor. That being said, like any new medication, when a company wants to have people trial it and see how it works, they have all sorts of programs through the company, and it's supposedly potentially available for less than $30 per fill, which is to say, if you get a 14-day supply, and right now, most of these trials have looked at it for about 14 days post-operatively. That whole prescription fill should be about $30 with some of these programs. And so I think they're really trying to make a big effort, which I think is very smart, to have it fairly readily available for everyone with a prescription. So you don't need to be part of a clinical trial. It is, clinically FDA approved for everyone. But obviously you want to have it filled at a reputable pharmacy, that's for sure.
Oh, that's so perfect what you said. So for the patients listening, when you go to your pharmacist, and I believe this is who you would ask, you can both speak to this, ask about those programs. Those are so important because it does reduce the cost. So yeah. What did I leave out? Oh my gosh, I know there's 100 things, but are we going to do a follow-up? Are we going to, what did I leave out?
No, I mean, I think we should, because I have to say, Terry, this experience, people always ask like how being a patient for something that I treat day in and day out has changed what I do as a surgeon. And, I'm going to start implementing this in my practice just based on my experience. And so I will have more information I'm happy to share with your group and anyone else on how it goes with different insurances. I would love to have this be part of the pre-op medication we give at the surgery center with our ERS protocol medication. So we'll see how that goes. But I think this is, in my mind, your toolbox concept is such a good one because I think you and I both are so supportive of people advocating for themselves for choices and getting to know all the choices.
Yep.
And so what I think for this is that there are, some surgeons who think a ton about nerves and postoperative pain and ERS protocols and regimens. In some places, it just hasn't become standard or taken on kind of the same level of importance. And I think this is a great opportunity for patients to ask about in general, like what is my perioperative pain medication regimen, pain management program going to look like? And then going into it, right? So much of this is expectations and everyone's different, but at least okay, I'm getting a nerve block with a medication that might last 1 to 3 days. Great. I'll have that to expect. Here's you're going to be your baseline and here's what's coming in. And it really does, I think, make a big difference. And so I would just add this is one more thing to ask about and advocate for as part of wanting a surgeon that's going to really consider the impact of your perioperative pain regimen.
Yeah. Well, so you already know it's going to be on the Deep Sea Journey podcast, DiepCFoundation YouTube channel, in the show notes and in the YouTube video once all of this gets published. Look for Ziv and Anne's Instagram. I'm going to put it on there. I'm going to put information, how to reach out to them, all the things, because we do not live in silos. We share this information. We spread it. We sprinkle it out wherever we can, because we don't know which ears it's going to fall on. And the important thing is, like you said, Anne, to get the information out, to educate, to inform, and provide the choices for patients. So thank you both.
You're very welcome.
Such a pleasure always. We really appreciate your sharing this with everyone. And like you said, you never know when someone's going to need it. So thank you, everyone.
Happy healing. Go pick some lovely produce today. I put my husband in charge of dinner. Our tomatoes are bursting at the seams right now, so I don't know what we're having for dinner, but happy healing, Anne. And Steve, thank you for all you do. I'm overly impressed that you were in your wife's surgery. I can't even tell you.
Thank you. Really appreciate the opportunity.
Take care, you guys.